Good afternoon and happy Friday, everyone. Welcome to the COVID-19 Learning Community. This meeting is hosted by the COVID-19 Command Center and powered by the Joint Information Center. Let's go over some housekeeping first. By default, all participants will be muted to minimize distractions. For Q&A, please use the raise hand function at the bottom of your screen. When called on, please unmute your microphone to ask your question and remute your microphone when not speaking to minimize background noise. When speaking, please announce yourself and speak slowly. You can also enter your questions, comments into the chat panel. Please hold all questions and comments until after the presentation portion of the event. Today's meeting objective is to review the current state of the San Francisco COVID-19 epidemic and local indicators of hospital capacity, disease situation, and disease control and current testing efforts. Also, to solicit input on the new online system for case investigation, contact tracing, CalConnect, and its use of the program's virtual assistant to improve and expedite care for people who are COVID positive and their contacts. And also to describe early stage planning for community rollout of a safe and effective COVID-19 vaccine. Here's today's agenda, and let's welcome Jeffria Morris, the Equity Officer of the COVID Central Command. Jeffria, the floor is yours.
Hi, everyone. As I start the meeting off for my last time. So this will be my last community learning event as the Equity Officer at COVID Command Center. It has been a wonderful ride for the last, I think, 12 weeks or more that I've been a part of our Community Learning Center. And I'm really most proud of starting this event, but also each one of you that tune in every Friday at 1 p.m. and really get the information out to community members. We specifically targeted 6 district areas, District 3, Chinatown, District 5, Western Addition, Japantown, District 6, the Mission in Portland, District 9, the Mission in Portland, District 6, Tenderloin, Treasure Island, South of Market, District 10, Potrero Hill, Bayview, and Viz Valley, in District 11, Excelsior, Outer Mission, and OMI. And these are the areas that we continue to see the spikes with COVID. And I'm so thankful that all of you, mostly from those areas that I just named, are here to receive this information and share in community, share the slides and the documents that we send you after the meeting into your listservs, newsletters, and everything, because it's so important that every San Franciscan, regardless of how much you make, how much you make or where you live, or if you are a person experiencing homelessness, that you are aware of how to fight this very dangerous virus. So I thank you all that tune in and really ask insightful questions and really keep us on our toes about bringing pertinent information that you need to do your jobs in community. You are the rock stars. All we do is provide the forum for you all to shine and ask questions with the people that's making decisions on all our lives. As you all know, we're in the red tier. I'm sure Dr. Fuchs will tell you even more on this. But in addition, I wanted to introduce you to my successor, D'Anthony Jones. Amazing young man, under 30. So he'll be pushing my old self out of here and welcoming a new, more even vibrant person to this role. And he will be the one that will be welcoming you each Friday. I also want to know, before I yield to D'Anthony, just to say a few notes, to say a few remarks about itself, is that we are going into holiday season. And so we will be going bi-weekly. As you know, we had a break last week. We're here again, and we'll have a break next week. So it'll go on that cycle. Christmas does fall on a Friday and New Year's Day. So after December 18th, we will not be coming back until January, the first Friday in January. I just want you to just have that on your mind. And we'll continue to let you know, as the weeks go by. So without further ado, D'Anthony, can you just say a few remarks for yourself?
Yes, I'll keep it very brief. First of all, thank you, Jafria, for just all of the work that you have done and continue to do for our city. I'm looking up to you, and I'm looking to you for an example on how to really take the passion to the next level in this work. So thank you so much. I got big shoes to fill. I know a lot of you on this call, and of course, I know and respect all of you, and definitely looking forward to working with each and every one of you to make sure that we're taking care of our fellow citizens, we're taking care of our city family, and getting through this storm. And of course, there's a lot of personal storms. I dealt with this with my family last month. Two COVID infections. In fact, my grandmother just came home yesterday. So I definitely, take an empathetic approach to this role. And I'm looking forward to working with all of our city partners, city agencies, our community-based organizations, and all of you. Please keep me accountable, hold me accountable, help me grow. I'm not perfect. I will make mistakes, but I will evolve. And to do that, definitely want you all to keep my ears open and keep my mind open, and just lace me up with all the information I need to do this job effectively. And with that, once again, I'm looking forward to working with you all. Congratulations, Jafria. Looking forward to you in City Hall. Just make sure it doesn't become City Hell for you. but bless you so much, Jafria. And I'm looking forward to seeing you grow, and I'm looking forward to this role.
All right, before I say back to Dr. Fuchs, I should let you all know where I'm going. So Monday, D'Anthony gave it away. Monday, November 30th, I will be going to City Hall as the legislative aide for District 11 for Supervisor Safai office. So just letting you all know. So I'm not far away. I'm in City Hall to help community, especially our most vulnerable, because I've been doing this work for over 20 years. All right, without that, now we got all of that done. It's like we on tour.
Our next presenter, is Dr. Darpun Sachdev, who's our lead for case investigation and contact tracing, and is doing some extraordinary work with the team to launch a new system that we're using for that. So Darpun, the floor is yours.
Sure. I know you all have a packed agenda, so I'm going to try to move quickly. But thanks so much for having me. I've been in the role of leading our case investigation contact tracing team since March. And I'm here to share a little bit of our data, as well as where we are as we're preparing for surge, as well as transitioning to a brand new medical record system this week. But I just wanted to share some bright spots in terms of how far we've come with contact tracing here in San Francisco. We are really a model for tracing statewide and nationally even. These data summarize our data from August through October of 2020, so 3 months, at which time we diagnosed about 5,000 cases, among which we successfully interviewed 85%. Among all cases identified, 44% identified a contact. Among all cases who were identified, at least one contact got tested, and then the big point here, among all cases that were reported to the health department, we were able to identify 15% that had at least one contact test positive. So it's just really important to note just how many additional cases contact tracing can identify in our goal to identify cases quickly enough so that we can prevent onward transmission. So a little bit in terms of the story behind our curve and how we've been doing with specific populations. These are our data now stratified by race, ethnicity. And you can see here, I think, something that we're really proud of in the Latinx population, which makes up over half of all cases, 2,600. We were able to successfully interview 92% of cases, among which 48% of all cases reported at least one contact, and 22% of all cases had at least one contact test positive. So you can see that orange bar, this last bar is higher than the average, and also higher than all other race ethnicities. I do want to call out that we did see lower rate of interview among Black African Americans. And so this is something that I hope that in future conversations we could work together in terms of how we can improve that. You know, our services offered through the health department all start with engaging in this interview, and it's at that point in time that we then are able to link people to services, including right to recover, as well as grocery, access to isolation hotels, and then further supporting their close contacts in getting tested. To that point, something that we look at very closely is among contacts that we identify. So during the same period that we had over 5,000 cases, we identified 6,000 additional contacts. How successful were we in being able to support all contacts getting tested? And then what was the positivity rate? And again, among Latinx, about 2,500 contacts overall, you can see 55% were tested and 21% tested positive. So this is a really high positivity rate that we're seeing among close contacts, particularly that are Latinx. You can see for other race ethnicities that the rate of testing is actually higher among the contacts, and the positivity rate is lower. And then the final piece that I just wanted to highlight in terms of our prior data is that we've been really trying to work faster in order to get to our contacts and make sure they have the information and the resources they need in order to properly quarantine. We did this comparison from where we were in May to where we are now, and back in October, and you can see that from the time that someone develops symptom, the median time to getting a test is about a day. Still takes about 2 days to get that case imported and reported to the health department, but from that point forward, it only takes a day for us to interview them and then also notify their contacts. And then finally another day to get the contact to testing. So overall, we want to see this time period, this lag time between someone developing symptoms to when their contacts are notified. We need to see it shorten, because as we know, COVID spreads rapidly. People can start developing symptoms and be able to spread to others within 2 days after they were exposed. Most people, it's around 5 days, but this 4-day time period is still, unfortunately, potentially too long, and we need to shorten that. So with all of that great work now behind us, you know, still a mountain to climb, because we are seeing higher cases, as Jonathan was pointing out, here in San Francisco, and continue to see high rates, particularly in the southeastern part of the city, where we need to maintain our focus and continue to do the good work that we've been doing. So something I wanted to talk about is, like, how are we going to prioritize, knowing that case rates are going up in all neighborhoods citywide. Some neighborhoods are having exponential, really like doubling of their case rates over the last month. But we want to keep our eyes focused on serving the communities that really benefit from the resources provide. So part of that is, as part of this transition to this statewide platform called CalConnect, is the ability to offer a virtual assistant, which is a text messaging system that allows us to contact people like hundreds at a time if we're getting those lab reports in, and then also allows us to prioritize people based on their responses. So, you know, we've been just started using this technology this week. As of a couple of days ago, we had sent about 400 surveys and had gotten about 36% of people responding. It's important to note that a lot of the people that respond are, you know, younger people. We noted that the response rate among people identifying as white was up to 50%. And that by utilizing this information, we were able to reduce call times with individuals who were responding. This kind of gives you a sense of like what the interface looks like. So one of the first questions is, can you quarantine or do you need support quarantine? And letting people know that the health department has resources. And I think what I wanted to stress is that, you know, we are committed to making phone calls in addition to sending out the virtual assistant to our most vulnerable populations, particularly focused in the southeast end of the city as we experience increased cases. But we do need more messaging to community members that it's safe to use this to respond to these texts in order to provide us data and let us know if they need help immediately. So this shows the flow of the questions that people get when they have to respond to the VA. The first step is actually an authentication step, and at which point people provide their language, because this is completely offered in Spanish as well. And we have had about 10% of our respondents provide us information using the Spanish version. But if they need support to like respond no, you know, off the bat to that second question, because then we can prioritize those cases as we are receiving many cases, you know, over 100 per day right now. And we can make sure that those people are able to get the resources they need as fast as possible. We also have a version of this text messaging system to notify contacts. So people should also be aware that if they get notified, you know, to take it seriously and engage in the program so that they, again, can get the most rapid access to services. Yeah, so with that, I wanted to see if I have any time for a few questions. You know, this service is available in Spanish, but we really believe that, you know, in many ways, by utilizing this feature, we can, it will allow us to have more time to focus on populations that are more vulnerable, as we're seeing all San Franciscans being more affected by COVID at the current time. So yeah, any questions I can answer?
Great. Thanks so much, Darpun. Any questions or comments about this new feature and our ability to outreach community?
I know I have a question. Darpun, so when you all get the positive testing and when you get the contacts, you just send in a text to everybody, just a blanket text, or, and then how do you know, is in the text people saying like confirm that you've received this, or is it any kind of checks and balance on that?
Oh yeah, it's a two-way conversation. So like if someone's getting notified, this is the contact script right here. So they are first being told like that they're being reached out to by California, the California COVID team, and that we want to get in touch with them. And then that individual does need to authenticate with their zip code, that it is them. And then, you know, there's a series of, there's like information that's provided in that moment to say, you know, you're being notified because you've been exposed to the disease, and we want to follow up with you, but here's a way to sort of get that process started faster by answering some of these questions. Some people who get these texts may have already been notified by like their family member, for instance, that they were exposed and they may have already tested for COVID. So it allows people to, you know, also just engage with us before we may get to them by phone.
I have a question.
Yeah.
So it's a couple of parts. One, is this in different languages? Two, what do you do? Are you sending this text out if it's a young person under the age of 18? And then three, how do you, if the person tests positive and then you send it, can you be sure that the folks that are getting it are the actual people that's supposed to get it? Because some people change their phone numbers and it could be somebody else's phone number and then you're gonna scare the crap out of somebody.
Yeah,
So,
those are, you know, awesome questions. So this is completely available in Spanish as well. So one of the first steps is, I think the first step is like your preferred language. when the text goes through to an individual. And we have had about 10% of people respond through the Spanish version. The vast majority of people that have responded in English. And we don't think that this is the ideal solution. You know, this is not something that we're going to be heavily promoting, you know, among our Spanish speaking populations, because we want to call them on the phone, but they will have an opportunity to respond to this text as well, because we are sending it to all people, to your second point, who are over the age of 18. So if you're under the age of 18, you won't be getting this text. For all of the people who are under the age of 18, we have to have parental consent if we talk to them directly. So we continue to call those individuals. And then your last point, in terms of making sure the identity is secure. So this authentication step for the cases requires zip code as well as, I think, date of birth. In order, you have to, it's like a two-step authentication in order to fill out the complete form. And I think as of this morning, we had like close to over 250 people who had responded to this, about 40% overall of all the people who had received the text.
And then question, I just want to clarify and make sure that I heard you correctly. Did you say that you are not promoting this in the Latino community because you want to call them on the phone?
Well, we are sending it to everyone in the whose phone numbers we have who are Spanish speaking in the Latinx community. We're sending it to everybody, but we're going to ensure that we also make a follow-up phone call to all people who are like to the neighborhoods where there's a high proportion of people of color. We really want to prioritize that warm touch within those communities. So this becomes something that maybe that a way for us to prioritize and make time for us to serve those communities with the same focus that we've been doing for the last several months. And recognizing that we're under pressure right now because we're seeing cases all over the city. You know, the spread is just so much wider, you know, Pack Heights, Presidio, Sunset, Inner Sunset, like all of those neighborhoods are experiencing increases, and many of them at rates that are much faster than the neighborhoods that have already been very impacted. Does that make sense?
Definitely. Thank you so much.
Okay.
To Darpun. And I also hope, like, I know that our Spanish speaking population is half of those tests, but I hope that the text will also be in our threshold languages as we continue to roll this out, because I know you've been having capacity issues with the need of more contact tracing.
Exactly. Yeah, we'll work with the state on making, because they've created this platform on making it available in more languages. That's a really great point.
Thank you so much. Dr. Fuchs?
Yeah, sure. So thanks. So we had a really robust discussion 2 weeks ago about COVID vaccine trials, and we're going to continue that conversation. We're really excited to have Dr. Hyman Scott and Rafael Gonzalez, who joined us our last time, to talk about the current COVID vaccine trials and some incredible news, even since we met 2 weeks ago, that's been released. So talking about that. And then we're really excited to also have Dr. Andrea Tenner from COVID Command, who's going to speak, just provide some background around our thinking about the rollout plans for a COVID vaccine and some of the early stage planning that's happening, and wanting to share some of that. And this will be the beginning of many conversations in the future with this group and with many community partners about COVID vaccine. So with that, Hyman, you have the floor.
Great, thanks, Jonathan. So I'm Hyman Scott. I'm one of the investigators here at Bridge HIV, which I'm going to try to share my screen. All right. Is that showing up okay?
Yes.
Okay, perfect. So what I wanted to talk a little bit about is just sort of how we as in our research work, we have primarily focused on the past on HIV prevention trials and have shifted towards COVID-19 trials. So I have a little bit of the data from the Moderna and the Pfizer studies, but also just wanted to highlight one of the things that has been central to the work that we've been doing here since the beginning, because HIV has disparities similar to the ones that we see with COVID-19 and honestly with most diseases in this country. So just to recap, these are the US COVID cases from today and deaths from today from the CDC website. And like many other diseases, this is not equitably distributed across race ethnicity, most disproportionately impacting Hispanic Latino individuals, as well as Black African American individuals for cases. And then among deaths, African Americans being at a higher risk compared with other groups. And so one of the things, and I have a slide about medical mistrust, and really just highlighting that there's a reason for the distrust, and it's based on history, and it's focused on those who are in power, essentially. So institutions and the staff who represent dominant cultures within these institutions. So two examples of this are the Tuskegee Syphilis Study, which just quick summary, it followed 600 Black men in the South to see what the long-term implications of syphilis were. Even after treatment was available, it was denied to these men, and there was infection spread to spouses as well as children. And it was known about that this was going on, and it was actually only stopped after media covered the experiment, and there was such disgust and outrage that this was allowed to occur that the study was stopped. And there's also other examples. Another one was in Guatemala, where 1,000 men and women were intentionally infected with STDs, while only some of them were treated. And this was only discovered actually during the Tuskegee Syphilis Experiment investigation. So just giving the context for why the distrust exists, and that it extends beyond just these two studies, and that there is, particularly among healthcare providers, and similar to what we're seeing with COVID-19, when there's a politicized component to it as well. And just day-to-day experiences of racism and discrimination that occur within our health system, and not adequate representation, discussion, information about research and opportunities, and that a study that is focused on HIV, for example, which disproportionately impacts African Americans in this country, and a study that does not include a fair representation, feeds this perceptions of that the results don't apply. So one of the things that that I always like to highlight is that in response to many of these, including Tuskegee, as well as the Guatemala STD Experiment, is this report called the Belmont Report, which is really about these three principles that guide how we protect research subjects. So first and foremost is respect for the autonomy of an individual to make their own decisions through an informed consent process, which explains the risks and the potential benefits. This is research, and we don't know what the answer is. So it is our ethical obligation to ensure that we're being truthful and transparent about what we know and what we don't know. And that many of these studies, it's not clear that there's going to be a benefit until the study is completed. And that as part of that, we are to do no harm and to minimize any risks and maximize benefits. So there's several ways we do that, including ensuring access. So many of our study participants, for example, we help navigate to healthcare to ensure that they have access to care. We do offer some local care for things that come up, even if they're not related to the study at our site, by the physicians and nurses that are taking care of our study participants. And then I think most importantly is this idea of justice, and that the risks and the benefits for the research should be equally distributed. No group should be asked to take on more risks than another. and to potentially have fewer benefits than another group. So where are we now with the vaccine? So we now have 2 studies for COVID vaccines that have been in the media, and I will caveat this this component because this is all based on press releases, and we generally depend on peer-reviewed publications so that the data are vetted, but these are the data that are reported. So in the Pfizer study, they enrolled about 40,000, more than 40,000, 3,000 people. They saw 95% efficacy, so there were 170 cases. This study, by the way, is complete. They have met their outcomes, and so they are going to be following people in the study. And they only saw 8 COVID infections in the vaccine group compared to 162 in the control. And there were 10 severe cases of COVID, 9 in the control and 1 in the vaccine group. In the orange box is the diversity that has been publicly shared from the Pfizer study. So if you look at the far right column, about 10% were Black, African American, 13% were Hispanic, Latinx, and 5.5% Asian and 1% Native American. The Moderna study reported results a week after Pfizer did. We don't have all the data on this study, but we do know that they enrolled more than 30,000 people. 37% of study participants are reported from racial and ethnic minority groups. It has a remarkably similar efficacy. Again, this is preliminary data. And they saw a similar number of severe cases of COVID. All of them were in the placebo group, and none of them were in the vaccine group. So this is preliminary data, and so they have not completed the follow-up, and so there might be more severe cases, and these numbers will likely change. In which direction, we don't know, but this is pretty remarkable that 2 independent studies show a similar result. And so in San Francisco, what we're doing is the AstraZeneca trial, which I know that my colleague Raphael presented, and we plan to enroll approximately 500 participants. We are prioritizing access based upon the unequal distribution of COVID in the community. We want to have a cohort that reflects the communities most impacted. And so at our site, we have so far enrolled about 88 participants. I think we're now at 90 as we're doing enrollments right now. And 30% of these participants are Black, 41% are Latinx, and 11% are white. And our role is to hold ourselves accountable. And part of that is sharing the progress as we move through this study around ensuring that we have representation. And I can tell you from the stories that we've talked to people who enrolled into the study, we always ask what their motivation and interest in participating is. And I think similar to what was shared earlier, there are people who have been, significantly impacted by COVID, who've lost family members, parents, grandparents, and are really wanting to participate in the study to ensure that it does represent the communities that they are seeing impacted in their own lives. And so that has been a strong driver of why people are interested in volunteering. So just wanted to end with this, this is from May, and so this is before we had any vaccine efficacy data, but essentially suggests that about half of Americans said that they would not get a vaccine if it was available. So I will either pause for questions or pass it off to Andy, however you want to.
Yeah, Dr. Scott, I see that Uzuri has a question.
Okay.
So first chart, there's no white people. And then this one right here. So here's my issue. And so we had to fight to get testing in our communities, right? Testing done everywhere else but in our communities. Yet for this vaccine, you guys want to come into our communities. And I'm almost willing to go out on a limb because now you've put 11% white, which I'm almost willing to bet that 11% white are actually mixed Black, Samoan, and Chinese, and they're just putting white. So the issue I have is that, you know, again, and then you came with this whole Tuskegee. We know all of this. This is where the problem comes in the first place. This is COVID. You want our communities to be the guinea pigs, but yet we were not guinea pigs as far as testing us for COVID in the first place. So I'm trying to figure out why and I know why all of a sudden, but it's basically the same thing of the slides you just presented in the beginning. And I'm just going to be quite frank with it. I mean, it's not right. It's hella disrespectful. And I don't care how you call it. And then I'm just looking at that first one. I'm like, there's not one population of white on there. It's always us that has to test the vaccine to make sure everybody else is going to be okay.
Thank you. Dr. Scott, Uzuri, do you want to comment on Uzuri's concerns?
Yeah, so you know, most studies are actually majority white, and so I think that it's an accurate criticism around what happened during testing when testing rolled out, and I think that as you point out, it wasn't rolled out in the ways that we would want it to be rolled out, and the question is there anything to learn from that process and acknowledge that it didn't go the way that we all would have hoped it gone? And does that mean that we should repeat that process for the COVID vaccine or other preventative treatments that we have? And in these studies, you know, I think what's happening is that the placebo arm is getting access to the vaccine when it's proven to be effective. And so these are the individuals who are going to get actually first access to the vaccines that come up. So I think that that it's transparency and acknowledging and talking and discussing and owning what happened, and also talking about what is it that's going to help us move forward and what is it that's going to help us to protect our communities.
Dr. Scott, can you go back to your slide that had the Moderna chart? Because I see we have in the chat about that. And I'm presuming, and correct me if I'm wrong, when we look at the data, the diversity of the chart, is the data to get to 100, is the rest of the people presumed to be white?
Yes. So these are data that Pfizer, and as I said, the caveat to this, we don't have the final published data in a peer-reviewed journal where all that data will be described. And so this is what's publicly available so far about the Pfizer study.
David, did I answer your question right, David Smith, or do you want to add? Okay, and then I have some hands up. I saw hands up. Oh, okay, go ahead, D'Anthony.
Yeah, and to follow up, looking at the vaccine trial demographics and who you're targeting, one notable admission from that is the API population. So, you know, as we know, this is also affecting the API population, from our Asian Americans to our Pacific Islanders, Southeast Asian population too. So I'm wondering, why did we not see any number for not just API, but even just Asian in general?
In this chart, or in
Dr. Scott, once you answer D'Anthony's question, that will be the final one, because we're going to move to the next presenter. Go ahead. I'm sorry.
I'm speaking in the vaccine trial targets.
So you're talking about here, or this chart, this slide?
Yes.
Yeah. So this is to focus on the populations that are most disproportionately impacted, and so we have also targets for Asian Pacific Islanders specifically, and the prioritization of access is the groups that we offer initial and prioritize access, and that's Black and Latinx, and it does include API individuals as well.
Thank you so much, Dr. Scott. And we're going to continue to maybe ask you to come back, because I mean, this is big. we might can get a grip on this virus with these positive vaccines, positive reactions to fighting the vaccine. I want to move on. We have one more speaker, and I apologize for everybody because these are pretty good presentations, and we should have allocated more time. So, Andy, are you ready?
Yes, yeah, I was just going to talk, and I can talk very briefly because I think this will be the first of many more discussions.
You have 6 minutes to go through. I'm
just to talk about
everybody after Andy finishes, just get off because it's over.
All right, I will be very quick. So thank you guys, first of all, for having me here and inviting me to come. This is an amazing group, and it's really an honor and a privilege to be able to be here with you guys. My background, I'm an emergency medicine physician at the General, and I also work in global health. And so I have been involved in responses to multiple outbreaks, including Sierra Leone during the Ebola outbreak. I worked there and ran Ebola isolation units there. And so now in this response, I am the operations section chief for COVID Command. And part of what comes under that role is planning for the COVID vaccine. So I will be honest with you guys, when Trump was talking about COVID vaccine being released November 1st, I was like, I don't know that I want to be involved in this, and I don't know what what is going on with this. I will say though that in learning more about it, so we have a California review board that we've said that FDA is going to review it, and then after that, California is going to review it, and our own Dr. Tomas Aragon is on that board, which is incredible. I felt a little bit better, but there's still a lot, as Dr. Scott mentioned, that we don't know, and there's, we've sort of joked that our job within the COVID vaccine group has been trying to plan to hit a moving target. But part of the reason that I'm here today is because there's really kind of two elements of the planning around COVID vaccine. So one is all the logistics. So it's, one of them is ultra cold storage, and that's not something we normally have. And so we were able to secure freezers for the ultra cold freezers, which is great because we had them delivered this week and they're on about 7-week back order now. So we have enough storage for about 600,000 doses of the Pfizer vaccine within the city. So there's those elements, and having each vaccine, the two top candidates have 2 doses, and how do we make sure that people get their second dose, and all of those elements. So that's one piece. The other piece is the most important piece, and that is how do we work to make sure that we are messaging out when we know what this vaccine looks like, what the risks are, how it was evaluated, that we are able to get that information out so people can make informed decisions. And how do we also understand from communities what the different challenges are? One of the things that I have learned through my work abroad is, there are a lot of different, if you are not a part of a specific community, there's a lot of different challenges and concerns that those communities may have that I as an outsider might never know. So I think I have learned a lot of humility through that. And that is where I think we as a city have to reach out to you guys and to all the representatives of the various communities within our incredibly diverse city. So I think what we want to know is what are people's concerns? So Ms. Peace Green, the issues that you raised, we don't want people feeling like guinea pigs with this. But at the same time, if there's something that's life-saving, we don't want people to not get it because they're worried about the feeling like guinea pigs. So how do we balance those things, and how do we understand what people's concerns are and where they're coming from? I know, even within the blind community, there's concerns about, how do people, if it's hard to leave your house and you're worried about feeling by touch and you have to stay 6 feet apart, how do you do that to come and get a vaccine? So there's, I think, a lot of different issues, and our goal is to make sure that everybody who wants the vaccine can get the vaccine. Now, we know that this rollout is going to be phased, so there's not enough vaccine that we have stored so far for everybody. There's very little actually when you look at it across the US. There will be increased production of it coming through, but that means that there's going to be a prioritization of who gets the vaccine first. We think that that will come from CDC and CDPH, but we are not sure what that's going to look like, but we want to make sure that we're ready to respond to it and that we have all the right people in the room to help us figure out how to do this. And how to allocate how to get these vaccines distributed across the city. So I think I've got 1 minute. So I wanted to bring that up and start the conversation because this is going to be all hands on deck, and we want to make sure that we are not missing something because we just don't know enough to see it. So that's where this, I think groups like this can be incredibly helpful for us. And we will be reaching out through our community, our equity and neighborhoods groups, our JIC, and trying to figure out how do we bring a community advisory board together to help us navigate this. So thank you guys so much for your time. I don't want to waste any of it. And I look forward to speaking again.
Yeah, no problem. And we can go over about 5 minutes. So Andy, don't move. I know my Tenderloin people have another meeting, but Yuzuri had a question, and I told her I would answer it offline if we went too far over. But the question is the trials, like what, if any, of the safety nets in place if vaccine does more harm than good in participants? Like,
so I think I can answer from the non-trials perspective. I think what we have for evaluation, so the FDA reviews to see what the data looks like. And as Dr. Scott mentioned, we haven't seen the data itself yet. So FDA will review it, and then our advisory board will review it. And our goal is to, our advisory board, if our advisory board, it's the state of California and now Nevada, Washington, and Oregon have all joined. If our advisory board says this is a no-go, even if the FDA says it looks good, we will not be distributing that vaccine. So
here's the thing.
Yes,
when you bring policies and procedures in, especially when it comes to Black and Brown, and thank you for pointing out about our Pacific Islander community, our API, because they are misinformed. So when it comes, there's two different sets of policies and procedures. And I'm gonna be very frank. There's one for white people, and then there's one for us. That's everybody else. And so sometimes people will cut corners when it comes to us in order for the greater good. And this is where the concern comes in. Because as we know, like even with COVID testing, again, and I go back to that because we had to pull tooth and nail to get our people tested. But now it's not tooth and nail to get the vaccine trials. And so how are we sure that, okay, well, that harm might not harm these folks. You might lose a finger or two over here. I think we can live with that. So how do we regulate that? So when you start talking about policies and procedures and those, they already don't work for us anyway, in a lot of ways. And so that even more so brings it. And I'm not saying that nobody should be in the trial, and that's not what I'm saying. But what I am saying is to make sure that folks are, if they are going to be in there, that there's that safety net, that there is authentic across the whole board, you know?
Yeah.
Like there should be a balance of so many this, some of this, some of this. Kind of like we do jobs. We don't give all the jobs to all Black people. We don't give it to all Hispanic. If we have 6 positions, we try and do one of each.
Now,
so that's what I'm saying, and I would be wrong not to speak up because the community's not in these aren't in these rooms. And a lot of people will go ahead and sign up for it because they either have it already or they just had somebody die of it, and so their emotions are in there.
Well, thank you. No, I appreciate you bringing that up, and I'll say the way that I deal with that part is by getting smarter people in the room to try to figure out what, and people who have the experience with that. And so I don't know, Dr. Scott, if this is something, because again, this is, if this is something that you can speak to.
Yeah, so there's several layers for safety. So one, there is the provider. So for example, all of our study participants have a pager number that comes to my cell phone if there's anything that happens to their health. So we're available. There is, if there's a safety issue that comes up in the study, it goes to our institutional review board, which oversees our implementation. That goes to another level of the FDA. So just as a reminder, this was a study that was paused for 6 weeks because there was 2 cases of participants. And so there was a 6-week pause to look at all the data and to evaluate and ensure that if the trial were to continue, that it would do so safely. And that was exactly what we want our safety nets to function and how we want them to function. Like if we need to pause or stop the trial because of a safety concern, then we do that. And so that's how the system was set up and that's how it worked. And so those are some of the safety nets that exist for ensuring that, you know, our priority is the safety of our study participants. And so if there's a concern for safety, then the priority is always on the participants. And the trial needs to either pause or stop or do something different if there's a safety concern.
Thank you all. So,
Jafria, you're muted.
thank you, Zuri. Thank you all so much for this, and we will continue. Vaccination will be part 3, and maybe all the questions can be answered because this is very important. This is impacting us. Thank you all. Have a great, safe holiday. I will be definitely connecting with our information and guidance to see what Thanksgiving information we have out to also send you via email. But have a great holiday and look to see you all again. I will not be narrated, but I will be in the audience. All righty. Bye-bye, everyone.
Bye, everyone. Happy holidays.
Thank you all.
Bye, thank you.
Oh, and Andy, can I have my scarf back now?
And thank you everyone for joining the COVID-19 learning community. If you have any questions or needs, please contact equity-neighborhoods@sfgov.org. Have a wonderful weekend, have a wonderful Thanksgiving, and please take care of yourselves. Thank you.